Good afternoon, everyone. I'm Ken Wong at the Regional Geriatric Program of Toronto, and I'm very pleased to be here today to walk you through this webinar. Thank you for registering. There's been outstanding interest in this webinar. I just want to go over a few of the webinar instructions so we can all make the most of this experience. As you all know, we are using a teleconference to provide audio for the webinar, and you may have noticed that an announcement that you were on mute happened when you signed in. So because of the large numbers at this event and us trying to avoid the event sounding like an outdoor food market, we will offer questions and the opportunity for discussion through the chat space. You will see that it's a large window on the right bottom corner of your screen, and there's a line at the bottom which you can click on to type in a comment and question. And we built in a few pauses in the program where you'll be queued to ask questions and have them answered by our speaker, who I'm very happy to introduce. This is a webinar on the Ontario's dementia strategy, and as such, we've invited our partners at the RGPs of Ontario Network to co-host this webinar for us, and they are all listening in today. Our special speaker today is Michael Robertson, who comes from the Ministry of Health and Long-Term Care. He's the Director of the Capacity Planning and Priorities Branch in the Strategic Policy and Planning Division. Now, this branch was established in July of 2015 with a mandate to develop a framework for the delivery of future healthcare needs in Ontario. Previously, the branch was the Ministry's Transformation Secretariat, and one of their signature programs is HealthLinks. At the moment, this branch has been tasked with the development and delivery of a dementia strategy, the topic of today's webinar, which is mutually supportive of a dementia capacity plan. This was launched by Minister Eric Hoskins in May 2017, just 2 months earlier, not quite 2 months ago, and will be supported by a $101 million multi-year investment strategy. The branch has also been tasked with leading the development of an alternate level of care strategy. And about today's speaker, previously Michael was a Senior Policy Advisor to the Deputy Minister and a Senior Policy Advisor on Infrastructure in the former Ontario Ministry of Energy and Infrastructure. So I'd like to welcome you all. I think just all of us, by being here, show that we are members of the Coalition of the Willing to improve and do the best we can for those patients and families who are experiencing dementia. Without further introduction, I'd like to thank the team at the Ministry of Health for presenting and turn you over to Michael.
Thanks very much, Ken. It's a real pleasure to be here and have this opportunity to talk to the regional geriatric programs this afternoon. Some of you I've had the privilege of meeting and having conversations with, and some are new friends that I'm just meeting for the first time today. So I'm here with a couple of members of my team, Adam Morrison and Anna Sternino, and we're going to walk through this presentation. And as Ken said, there's some opportunities we'll build into it for questions and for comments and feedback. But I also want to say that this is not a one-shot kick at the can on this one. If there are questions that we don't get to based on the time, or if there are things that I need some time to do some more research on or think about, I want to keep this conversation going. So I'll put it right up at the outset for people who want to get a hold of me post this webinar. It's pretty straightforward. It's michael.robertson@ontario.ca, and I'd be more than happy to talk to any of you and all of you and answer questions that we may not get to today. So as we move through the slides, let me see. Let's move to the next. Oh my goodness, technology, magic. So overview. Today I want to talk about the purpose of our presentation. I want to provide you with an overview of the government's commitments. I want to talk a little bit about our vision for a coordinated healthcare system for people living with dementia. I want to talk about Ontario's work to date on the development of a dementia strategy, our 5 key pillars of that strategy, and the key investments that, as Ken mentioned up front, the Minister announced at an event a month or so ago. Talk a little bit about some next steps for us, and then have an opportunity to take your questions and comments and feedback on what we're talking about. So the government commitment, Patients First, the Action Plan for Healthcare, was launched by Minister Hoskins in 2015 with the vision for health system transformation, which included improved access and a commitment to improve dementia supports. Improved dementia supports were also in the 2 mandate letters that were received by Minister Hoskins from the Premier, as in his role as the Minister of Health. And for the first time, in my experience, with this government, those letters were not just sent from the Premier to the Minister, but they were posted online. So everybody across the province could see the direction that was being given to the Minister and, of course, by extension to the Ministry. We were delighted to see that in the government's budget at the end of April of this year, over $100 million over the next 3 years was committed to the dementia strategy, to the implementation of the dementia strategy. And an announcement was made by Minister Hoskins up at Baycrest at the beginning of May, and we'll talk to some of the pillars, if you will, or the investment pieces that the Minister spoke to at that event at Baycrest. So I joke when I give these conferences that I've nailed this vision above the door of the staff that are working on the dementia strategy. I haven't really, but we do start all of our meetings with a discussion about what our vision is, and it's to ensure that people with dementia and their families and care partners are treated with respect, have access to information that allows them to make the best possible choices regarding their health and well-being, and are living well with dementia as they define it, helped by appropriate services and supports where and when they need them. And our approach is to address the increasing prevalence of dementia and the resultant pressures on the healthcare system, and to divert people living with dementia away from ALC or from alternative level of care in hospital, away from long-term care where possible, and keep them living safely in the community for as long as possible with the appropriate supports and programming. We want to make sure that we also reinforce key areas of our healthcare system with best practice supports and better training and education. And we're looking at that across the entire continuum of care. We want to make sure that the specialists are involved in this training, that they're helping us understand what needs to be taught and what education needs to be disseminated. We want to make sure that everyone across the continuum is getting care, who's getting care has the training that they need to support the clients that they're supporting, and that whether that's a PSW, whether that's a nurse practitioner, whether that's a primary care doc specialist, a home care nurse, we want to make sure that the education exists for them to be the best they can be in treating the patients that they are seeing. The work we've done to date has been fairly extensive, and we've seen a great part of the province over the last 2 years. We've worked really hand in glove with the Alzheimer's Society of Ontario, who has helped us emphasize the need for a long and comprehensive engagement period. We started back in the fall of 2015, really asking questions about trying to understand what we didn't know about dementia, about cognitive impairment, about the system that was in place. We had a series of roundtables. We moved through, we developed an expert panel with a wide range of representation at the table. We had clinicians, we had the Alzheimer's Society, we had advocates and representation from various associations, and most powerfully for us, we had representatives who were people living with dementia, and we had care partner representation at that table as well. We launched a series of working groups in the winter of 2016 that really broke out the dementia across the course of the trajectory of the disease. We started with healthy brain and looking at healthy brain and health promotion opportunities. We drilled down next on the early onset, early stages of dementia, and then moved to a working group on moderate stage dementia, and then into advanced stage, including end-of-life and palliative care. And had some really powerful conversations, and Ken LeClaire from the Alzheimer's Society and from Brain Exchange was a key voice in our ear on that, and talking about the importance of looking at that advanced planning and end-of-life stage for those living with dementia. Supporting all of that, we had a working group that looked at research and innovation. We wanted to make sure that we were understanding what some of the best practices were, not just in Ontario, not just in Canada, but around the world. We engaged the services of the Ontario Brain Institute and ISIS, as well as our own in-house research division to make sure we understood what the best literature was telling us. We launched a discussion paper in September of 2016, which really tried to encapsulate everything that we had heard and put in some probing questions. We took that on the road and did a series of town halls, also launched an online survey. We were astounded at the response we got to the survey. We had over 5,000 responses to it. By comparison, the similar survey that the ministry launched on medical assistance in dying had a few more, about 6,000 respondents to it. But it really showed to us the fact that we touched on a nerve and people really wanted to talk about their experiences. And all of that led to the budget announcement in the spring of 2017. And then we're working now on the dementia strategy rollout, and that's where we need we're going to need your advice and your help as we move forward on that. The key pillars that we use to support our work, the first was support for people living with dementia, ensuring that there were accessible supports and services to meet the diverse needs of people living with dementia. Secondly, we wanted to ensure that there were supports for care partners, flexible respite services that responded to their needs. We wanted to ensure that we had, as I said earlier, a knowledgeable and well-trained dementia workforce. We wanted to raise dementia awareness and promote brain health, and I'm reminded of an advertisement that came out of Australia that just had a picture of a man's head, and the campaign tagline was essentially, "What happens below the neck impacts what happens above the neck," and it really tried to tie together the importance of cardiovascular health and then later stage cognitive impairment challenges. So we're working with the Alzheimer's Society and we're working with our own communications folks within government to talk about how we can run a campaign to increase dementia awareness and promote brain health. One of the things that I'm really quite proud of in this work is a partnership we're building with our colleagues in the Ministry of Education, where we're looking to have somebody who's living with dementia and a care partner put into the classroom to talk to kids when they're in grade 7, 8, 9, 10, somewhere at that age, to really let the younger people understand what it's like to live with dementia, what some of the challenges are. It may be something that they're facing in their own family and they don't understand. So to actually have that as part of the curricula moving forward, I think would be tremendously helpful in reducing some of the stigma around dementia, around brain health, around cognitive impairment. And our fifth pillar continues to be around research and innovation. We want to work closely with the Government of Canada. We're in conversations with our colleagues across the country. We were excited about the dementia research that was done and the research strategy that was done by the Government of Alberta and Alberta Health. And just last week we were in Montreal for a conversation with Howard Bergman and some of his team to talk about implementation that's happening in Quebec, as well as some representation from some of the Atlantic provinces to pick up some of the successes that they've had in Nova Scotia and to help New Brunswick that is starting to follow us on this path. The next slide is the slide that was used when the minister launched this back at Baycrest at the beginning of May. And after this, I want to pause for an opportunity for questions. But if you can see this, it's the 10 key investments that we are looking to invest in with the money that was received in the budget. The first one is around dementia day and evening programs, which we're trying to find new language around that, new nomenclature, and we've come up with community dementia programs. I'm happy to take feedback on whether that's a thumbs up or thumbs down on that language. The reason we wanted to change that is we wanted to ensure that these programs are not just day programs. People living with dementia need the access to these services outside of just 9 to 5 or 8 to 4. They need them overnight. They need them on weekends. They need them over holiday periods. Secondly, we want to make sure we're investing in flexible respite for care partners of people living with dementia. And so we're in conversations with the LINs and with the Alzheimer's societies to better understand what our best practices are, what some of our centers of excellence exist across the province on caregiver respite. Thirdly, we look to invest in care partner education and training. This ties into some work that we're doing on the dementia capacity planning work that we have begun with cancer care, ISIS, and OBI. And what we've picked up on is a study that comes out of New York University that looks at a module for caregiver, care partner training, education, and ongoing support, and what type of impact that has on an expression of need for long-term care. And we've actually seen a material impact with this program being operational. We've tested it in Champlain, in the Ottawa area, but we are starting to see some interesting results coming out of that that enables people to live independently at home for a longer period of time. Pillar 4, if you will, is as I talked about previously, the dementia-specific training for frontline and primary care practitioners. We want to invest in behavioral supports, both in the community and in long-term care. One of the commitments that Minister Hoskins has publicly made is that he wants to see behavioral supports in every long-term care home across the province. And so to help the minister meet that commitment, we'll be looking to invest more money in behavioral supports in LTC. But we don't want to lose sight of the good work that's happening with BSO in the home and community sector, and the importance of the transitions between home and hospital and vice versa, where often we see challenges in the care, challenges in the care planning. We're excited about the concept of memory clinics, and we've had a lot of conversations with Frank Molnar, with Linda Lee, with others to talk about the success of primary care collaboratives. But we've also been talking with people like Jenny Ingram in Durham, and the GAIN clinics that she runs, and some of the work that Dallas Seitz, who's a mentor for us on a lot of this work from Providence and Kingston, is doing. What we want to do is make sure we fully understand the efficacy of memory clinics, both those that are new, that Arctic funded in early 2017, and those that have been up and running for a longer period of time. And we want to make sure that we have the evidence we need, that we can continue to support memory clinics moving forward. Patient navigation is the eighth pillar of this, and some of you might recognize through this language that we're referring to FirstLink. We're not exclusively referring to FirstLink that the Alzheimer's Society runs, but that's the model that we've been holding up as a gold standard. We do believe there, however, are others. We want to make sure that we have in place the ability for a primary care doc, once the diagnosis is received, to refer this patient immediately to a FirstLink navigator to help a newly diagnosed patient and their family with all of the challenges and the stresses that they're facing in that time, to better understand how to go through the system, how to move through through what is still a complicated system. Number 9 on this, continued investments in physician education and geriatric care. We want to make sure that we have enhanced capacity for specialists to support the entire health workforce and to respond to the needs of our aging population. And we've had some great conversations at the RGPO table with you and your colleagues about what this looks like. We've been talking with Dr. Sinha, and we've been talking with our colleagues here in the ministry in the Health Workforce Policy Group, Denise Cole and her team, that actually have carriage over this work. And then lastly, number 10, as I've spoken of, is the need for a dementia campaign. And we're working with communications here in the ministry and in Cabinet Office, as well as the ASO, to talk about how we can reduce stigma and have a more targeted campaign. So with that, I'm going to stop and pause anyways, and take questions, comments, feedback, and then we can move on after that.
It's Ken back on the line. This is a great opportunity. There's a lot to digest on the slide, so we will pause here, give you a chance to finish reading what's on the slide, and also give an opportunity for you to type in your question or comment. And you do so by clicking on the line at the bottom right corner of your screen, typing in, hitting enter, and everyone on the webinar will be able to see your comment. In the meantime, Kelly Kay, our colleague at the Seniors Care Network in Cobourg, adds that study of Howard Bergman through the Canadian Consortium on Neurodegeneration and Aging includes multiple Ontario sites as well. Lots going on in the province. A question about, yes, we are recording this session, and for those of you who missed an earlier part, we will send that recording out once it's available. So Jennifer in the Northeast Lynn, a question for you, Michael. Is there a role for public health to assist with brain health and awareness?
Thank you, Ken, and thank you, Jennifer, for the question. Yes, there absolutely is a role for public health. Some of the work that we've done elsewhere in this branch has been talking about population-based planning and looking at population-based health needs. And a lot of the work that's been done on that, the groundwork that we're following, has been done by public health, by both the division population and public health here within the ministry, but perhaps even more importantly, the regional public health agencies and public health in the municipalities. So yes, it's very much top of mind for us.
And Kelly asks about primary care models, such as primary care geriatric assessor clinics. Would they be considered?
Yes, thank you, Kelly, for the question. And yes, we're looking to make sure that we're having a look at all of the models that exist right now. As I had referenced when I talked about in the pillars, we've been talking with Jenny Ingram from Durham about the GAIN model that she runs, and we've also been talking with Dallas sites about some of the nurse-led clinics that are out there, and we're certainly aware of also some of the specialist-led clinics. So we want to make sure that we're looking at everything that's in the field as we do an assessment. It would be we wouldn't have as good a result if we didn't look at everything that was currently in the field.
Great, and we have a question from, I believe, who is coming from a caregiver perspective. Carol Ann, her sister-in-law has dementia and lives 2 hours away, and whose son lives 4 hours away, and what's challenging for them is getting local support. Is that being factored into the current strategy?
It is. It's an excellent question, and we've heard it time and time again, the need for transportation initiatives. As we were looking at the day programs, or the community dementia programs as we're perhaps calling them, one of the key issues that came up was the ability to get there. And we're well aware that if someone has a recent diagnosis of dementia and has lost their driver's license, and they live at Yonge and Bloor in downtown Toronto, it's not as challenging perhaps to get to access services. But if they're living hours away from where treatment is being available, or where day programs or respite programs are being made available, it makes it out of reach for those individuals, or essentially makes it out of reach. And so one of the things that we've been looking at is looking at transportation. One of the successes that we saw earlier this year, early 2017, which was here in Toronto with the Toronto Transit Commission, that up until the end of 2016 had a policy in place that said that their Wheel-Trans service, which is our mobility transportation in Toronto, was accessible, and you could be eligible for that if you were living with a physical disability. But if you were diagnosed with a cognitive impairment, that was not considered. You were not eligible for that program. And the TTC changed their policy at the beginning of this year, which I think is going to give people certainly in Toronto a better access to care. But we've also heard this conversation when we were in Waterloo. Again, fine if you're perhaps not such a huge challenge if you're living in Kitchener or in the downtown part of Waterloo, but if you're living in Elora, or you're living in Fergus, or you're living in a remote community, how you're able to access these services is critically important. And so a transportation lens is being layered over all of this, including some conversations with our colleagues in the Ministry of Transportation.
Yes. And
we're also making sure that we are making training available in class and online and through apps. Through some of our earlier research from a couple of years ago, we saw some of the efficacy of apps. I don't know, too old to understand all of this, but the ability to use mobile devices. We're seeing this with some of the work that the Reitman Center in Toronto was doing with under the leadership of Dr. Sadavoy, and we've seen it even in some hackathons where some apps have been developed that allowed people to access the services that they need, even if transportation is a challenge. So that's a lot of answer to say yes.
Yeah, it's a very complex but a very real challenge. So I'm glad all these multiple approaches are being considered. Question, I'm going to combine Ben's question with the Alzheimer's Society of Toronto team, and it's involving staffing. So Ben asks about additional home care support, and the Alzheimer's as well about staffing ratios for frontline workers.
Yeah, it's a good question, and it's work that we're doing as the ministry develops its home and community care roadmap and talks about what the levels of care should look like. One of the inputs that we've had the ability to put in to enable them to influence that strategy is the need for a level of care that addresses the needs of people living with dementia. We're also looking to ensure that we are investing, as I said earlier, in BSO in the community and in First Link programs to help with patient navigation. Certainly, staffing challenges, both on the number of staff on the front lines and the training that they have, is critically important to the success of the strategy.
Right, and Red Lake Hospital asks about acute care support. Are acute care hospitals going to receive support such as training and education? And I might add a little bit there because the RGP of Toronto and our colleagues across Ontario, the RGPs of Ontario network, have been very active in the senior-friendly hospital strategy and would welcome opportunities to collaborate and support hospitals in this area. But Michael, I'll turn that question over to you.
Thank you. Good morning, Red Lake. My goodness, that's a distance from Toronto. Some of our colleagues were up in Red Lake a couple of weeks ago, and we're so very pleased to get an opportunity to have a look around and see what was happening in healthcare in northwestern Ontario. Yes, the answer is yes. We recognize the importance of all sectors across the continuum in addressing the needs of people living with dementia. We've had some great conversations at the Royal Ottawa with Frank and Kelly, and some great conversations with folks at Baycrest, Dr. Reichman and others at Baycrest about the importance of the acute care sector in this work, and they're very much a critical piece of what will be our success.
Yes, and Caitlin adds, I believe this is more of a comment, but she stresses the value of Dementia Day programs Monday to Friday, though she's in Campbellford with relatively little access to such a program, but I think there's a vote for Dementia Day programs there.
Great. Yeah, I mean, we've had the opportunity to see some great examples of day programs and the varying clientele that are served. And some of the challenges that the team has been trying to address is how to make sure that we're offering the right, or that the right services are being offered to the right clientele in day programs. And I think to some of the examples we've seen where there's a day program that is generally targeted to people with later stage Alzheimer's, and somebody came to participate in the program by referral from the ASO, who was relatively early onset, early diagnosis, frontal temporal dementia, and took a look around and said, this program is not tailored to me, this is not for me, and so wasn't able to participate or didn't feel comfortable in coming back to that program. How do we make sure that those day programs address the needs of the people that they're meant to be serving? And as we said earlier about transportation, that people have the ability to get there.
Service de Counseling, HKS, asks if there are funding opportunities coming on the horizon.
Well, the government has committed $101 million over the next 3 years for the implementation of this strategy. We are currently working on what an implementation plan would look like. What we don't have from government today is approval to expend any of this money, so we need to be back in front of decision makers around the cabinet table later this summer for a conversation about where we think the what the allocation of $101 million would look like on a year-over-year basis, and then how we intend to roll that money out the door. So it is certainly our expectation that none of that money will be left on the table at the end of this exercise, but we have yet to receive formal approval from government on how each of these buckets that we talked about on the previous slide, or on the slide that's up there now, sorry, will be funded.
And Michael, I don't know if you have anything to add, but I think our colleagues at the Alzheimer's Society of Toronto wishes to remind us that dementia training and education should be offered for decision makers and administrators as well as clinicians.
I'll say here to that.
Yeah.
But on a more serious note, we would not be anywhere on this strategy without the partnership of the Alzheimer's Society. David Harvey was an early mentor of ours. That training us in what to look for and what to understand was critically important. And more recently, we've been having conversations with the Ontario Dementia Advisory Group, which I don't know if everyone's aware of. It's a small but mighty group of people who are living with dementia, they're represented on our expert panel, on our advisory panels, and they've been looking for an opportunity to participate in training of healthcare providers from the person living with dementia and from the caregiver or care partner perspective, and we think that's an excellent idea.
And Shirley and Sheila have comments coming from the caregiver perspective as well. Shirley regarding wait times for specialist assessments, and Sheila regarding drug plan coverage. Any comments on that or directions in that on those topics?
So on wait times, I'm just going to scroll up here if I can see the question. Oh, here we go. So I think, Shirley, we have similar concerns about wait times. We're working closely with Cancer Care Ontario as part of our planning work, both system-wide and on dementia planning, to look at what that access to care and access to specialists looks like. The ministry has set up a task force that actually it's called Access to Specialists. And we're at that table and advocating strongly that we be one of the first areas that the ministry focuses on looking at what those referral patterns, how those referral patterns work. And indeed, on the slide that we get to after this opportunity for questions and comments, we'll talk a little bit more on slide 10 about some of our thinking around referral patterns. And Sheila, the question about ODB coverage, that's a great question, and it's something we're going to have to get back to you on. We have a directors panel that has been advising us on the strategy development, and my colleagues, the directors at the Ontario Public Drug Program, have been following along on this, and we've had these conversations. We've also been following some of the research and the clinical trials around the hope for new drugs that may be developed and the successes or lack of successes that we've seen so far. So I can't answer the specifics of this question this afternoon, but I will get some answers on this, Sheila, and we'll get back to you.
I'll remind that we'll be sending out, along with the package, Michael's email address, who he provided to everyone at the beginning of this webinar. The Alzheimer's Society of Toronto, they want to point out that many local chapters have brain health sessions to increase awareness, and they, I believe, are looking for opportunities of partnership so they can continue delivering this education to a wider audience.
And we welcome that opportunity to continue to partner with the Alzheimer's Societies, both the provincial body as well as all of the local chapters. We've had some great opportunities to have conversations with the AST and talk about some of the specific programs that they're running with the Toronto Central LHIN. And I think there's really been some best practices identified there that we have picked up into some of our other thinking on this. So that's a partnership that I think will be continuing, that I know will be continuing, and not just with the AS Toronto, but with all of the other 28 chapters across the province.
I think after this presentation, you're going to be very popular in email hits, Michael.
That's okay.
And Dr. Liu here in the office, Barbara Liu, is wondering how the impact of the strategy will be measured and evaluated.
Barbara, thank you for that question. And we'll talk after this, but thank you for this opportunity to speak to the RGPs this afternoon. Every single every single initiative that we have on this strategy has an evaluation component built into it. We are working both within the ministry and with some of our key ministry partners to ensure that there's an evaluation framework built into every investment that we make. We know that we want to make sure that everything we invest in, and we want to make sure that it's having the impact that we're hoping that it's going to have, both on the clinicians, but more importantly on those who are living with dementia and on their families. We want to make sure that the work around dementia capacity planning, that all of that, those investments are that work is informing the strategy and vice versa, and that we have an evaluation process built into that as well.
And a question from Teresa regarding financial incentives for primary care physicians to accept these complex patients with dementia.
Yeah, that's not a question that I'm able to answer this afternoon, Teresa. It's part of the conversation that we continue to have within the ministry around physician compensation. As everyone on the phone knows, we've got lots of folks in different divisions across the ministry, both in our negotiations branch as well as in our health workforce policy branch that have the lead on this. So I'm not in a position to answer that question today, but happy to take further advice from you and keep that conversation going.
Yes, and Maria, and I'm guessing that's Maria Boyce from Cambridge, points out that they have embedded GPA training to new employees in their organization. Maria clarified that's acute care, which solidified my guess. Maria Boyce, is that you? In the meantime, Audrey and Jane ask about funding for new 24/7 programs that are enhancing existing day program models.
Hello, Audrey and Jane. Nice that you could join us this afternoon. I don't think there's any money for capital funding at the moment. The money that we have here, we've talked about here for enhancing these services is very much meant to be spent on an operational basis. We do appreciate that in some communities, the lack of availability of capital space is a challenge, and that's going to be work that we need to continue to address. But for the fairly limited dollars that we have available to us over the next 3 years, that money is all going to be earmarked to enhancing the operation of day programs.
Great. So I'll whiz through these existing questions. I want to point out to the audience that there will be a couple more pauses for questions, so hold your thoughts. We'd like to get through some of the slides and provide more material. But in the meantime, Mary Ellen is thanking you for the presentation and looking forward to further details. Sally is wondering about the power of exercise for brain health, and are there strategies to increase physical activity?
It's an excellent question, Sally, and thank you for asking it. Yes, there is. We're making sure that we tie the work we do here to existing ministry health promotion strategies around things like Smoke-Free Ontario, around the Healthy Kids Challenge, which is a program to address childhood obesity. And what we're doing, and I'm super excited about this, is working with ICES to track the children that are in that Healthy Kids Challenge through their entire life cycle, so that we see whether, from a research perspective, whether there's an impact on their cognitive abilities as they age, whether there's a difference in that because they were more actively engaged in physical activity and healthier eating as 7- and 8-year-olds. So that's exciting to us to see, and that's a long-term research piece that I'm happy to see the ministry is addressing. But certainly, and I had mentioned that Australia campaign about what happens below the neck and the impact above the neck. We are trying very hard to ensure that a strategy is in place to tie together cardiovascular health, physical exercise, diet and nutrition to a series of longer-term health impacts, including cognitive impairment.
can see the Alzheimer's Society in Toronto are jumping at the bits to create new programs and enhance services. Will there be an RFP for these funding announcements?
It's a little early to answer that question. We have some partnerships now with the LHINs, of course, and some of the money will be distributed through our LHIN partners. We do fund the Alzheimer's Society local chapters through the LHINs, and so that we certainly see that continuing. For some of the specific programs, I think it's a bit early to say for certain. We want to make sure that the money that goes out the door is allocated to the programs that have the most success and that have a track record of success. We've had some feedback from the LHINs as to what they see as their star performers, both in day programming as also in other types of respite, and we've been truth testing that with local chapters of the Alzheimer's Society, and we want to make sure that money that goes out the door goes to those more successful operators. That might be done through an expression of interest, and it might not be. We're not quite landed on that yet.
Kelly Kay adds, and seconded by Dr. Barbara Liu, is there an opportunity to insert mandatory AODA, the Accessibility for Ontarians with Disabilities Act, workplace training to include dementia-related focuses?
That's a good question, Kelly and Barbara. I like the concept. We'll take that back to our colleagues here in government and talk about and see what the plan is around this. We've had some of these conversations with ODAG, around human rights issues, civil rights issues for those who are living with dementia. And we've had some early conversations with our accessibility secretary in cabinet office, but that's a conversation that we'll need to continue.
I think we'll get back to the presentation. Just want to point out from William Osler that they're encouraging us to extend this collaboration across Canada.
Absolutely, and I'm glad that Osler's on the call today. We've had some great opportunities to chat with colleagues in British Columbia, Alberta, Quebec, and Nova Scotia, and most recently New Brunswick, and also with the Public Health Agency of Canada. And I think you would all be more aware than I am of the Bill C-233 receiving royal assent yesterday, talking about a national strategy. We have always had it in our mind that if and when the Government of Canada came forward with the desire to have a national strategy, that we would be first in line in making sure that what we had done and what we had built here, both from a policy, from a research, and from an operational perspective, could be lifted up into a national strategy. So we're more than happy to work right across the country with colleagues that are either a little ahead of us or on path or a little behind us to help them out.
This is some brilliant discussion so far. Let's all turn our attention back to the slide deck, and there will be a couple more opportunities for questions and comments. But Michael, I'll turn that back to you.
Thank you. So the next slide, some of you will recognize from Kaiser. It's our proposal, early days, on aligned diagnosis and referral throughout the healthcare system. And really what we want to show on this slide, and we'll talk through it and then happy to take some questions, is that the primary care providers are the front door to the healthcare system, and that they have the training and the skills and the ability to refer as required to specialists via e-consult or telephone consults, better training for diagnosis and for management of dementia. And then we're looking at, if you look up the next step in that pyramid, at the primary care collaborative memory clinics, but also all other different memory clinic models. We're talking with our colleagues in the LHINs about alignment to the relatively recent creation of sub-LHIN regions, and making sure that looking at whether or not there could be a memory clinic of some sort in each memory clinic, at least in each sub-LHIN, at least one. And then if we move up, talking about in-community supports around home care, respite, CCAC services, the day programs that we spoke about, and then ultimately up to specialist care with special subclinics, interdisciplinary response, and then we've capped that with BSO in LTC. But really the drive of this slide is to talk about what the proper referral patterns are, where we pick up the resources that exist in the system, which I think as we get better at that, we'll understand where the gaps are. We want to make sure that the specialists are seeing the most intractable cases only, and that the primary care docs and the primary care providers are properly trained or well enough trained to be able to diagnose and address the needs of individuals as they present. So I know we've been in some great conversations with Frank and Kelly from the RGPO, and Frank, thank you for sending up a bit of an amendment to the triangle earlier in the week, and you know, it's something that the team has been grappling with. As I say, this is early days on this, but I would love to pause here and get some feedback on what people think of this approach and some questions and comments.
Is there more feedback from the audience on this slide? Been great and lively discussion, Mike. I think in many ways this has almost been a focus group on ideas and needs and challenges as well.
It is. The things we've heard, Ken, from the group, I've got staff here who have been vigorously taking notes and making connections. So it's been tremendously helpful for us.
Now, Marlene had a question about the alignment of the dementia strategy with age-friendly communities.
Okay, thank you, Marlene. The short answer to that is yes. We want to make sure that there's alignment there. We've been in conversations with our colleagues at the Ministry of Seniors Affairs on some of the work they've been doing around age-friendly communities. We think that there's great connectivity between the work we're doing here and the work that's happening with MSA. We want to make sure that we've all seen the terrific examples from Europe coming out of the Netherlands and Denmark with the dementia communities. We've seen a great opportunity. A couple of months ago, we had the opportunity to visit the beginnings of an age-friendly community in the Niagara-on-the-Lake area, St. Catharines, and really want to encourage that. We need to understand it a little better, how it's funded, how it operates, how it's regulated. But yes, we want to make sure there's strong connections between that work.
Kelly Kay mentions, perhaps related to your mention of the communities in the Nordic countries, but what's the vision for retirement homes?
It's a good question, Kelly. We're working on part of our ALC strategy with the retirement home sector, with the retirement homes. Through the Retirement Homes Act, report to government through a different ministry. So we've had to really educate ourselves on how that sector operates, how it's regulated. If we look at long-term care regulations versus retirement home regulations, as you know, long-term care tends to be very heavily regulated around health care, patient care, safety issues. The retirement homes regulation and the Act are very much directed at consumer protection. But we are in conversations with that sector to see whether we could develop some type of transitional housing model to address some of our ALC challenges. As everyone on this call knows, people living ALC are often also living with dementia, and so we need to better understand that. But that is work that's happening right now, also with the retirement home operators.
Yes, and are the Sublin regions involved in developing complementary pathways?
They're starting to be as they come online. They're starting to be. Most of our conversations to date have been with the LHINs, and up until a couple of weeks ago with the CCACs. We certainly will be looking to, as I mentioned earlier, around memory clinics and the connection to the LHIN subregions to make sure that we understand what those pathways look like at the sub-LHIN or the subregion level. And we've had some great early conversations with our colleagues here in Toronto Centre about how we can make sure those pathways are in place at that regional level.
I'm going to combine two questions, Erin and Carol Ann. Erin asks about where access begins if people have no primary care practitioner. And Carol Ann mentions that the person who first makes the diagnosis, whether primary practitioner or other, ought to set in place the contact with caregivers, the CCAC, and other supports. Do you have some comments around that, Michael?
Sure, thank you. And thank you, Aaron, for the question. It's a challenging one for us. The issue about access begins for individuals with no primary care practitioner. It's still the ministry's goal to continue to connect everybody with the primary care practitioner. Clearly, we're never going to get to 100% on that. I think in cases where there isn't a primary care practitioner, to some extent we need to look at that on a case-by-case basis. We need to make sure that we have the conversation going and the buy-in from the community health centers for those who either don't have a primary care practitioner or are not covered by insurance in Ontario for whatever reason. And so those are conversations that we continue to have with the broader sector. And the next question about the plans to ensure the levels are collaborating with each other to ensure the success. I think that's a good question. Collaboration on all of these fronts would be absolutely critical to ensure the success of this policy, whether it's across ministry, whether it's through these levels that we have in the pyramid. And maybe I can take your advice from the RGPs on how that coordination and collaboration works across these lines within the pyramid.
Great. And Mary Ellen reminds us that not all of Ontario has all of these resources, so there ought to be some flexibility and perhaps a hybrid version of this pyramid.
That's a good point, Mary Ellen. Thank you. Agreed. We want it, and that's one of the reasons we've been working so closely with the LHINs, is to make sure that we understand what that regional variability looks like. We're certainly well aware of the challenges in the Northeast and the Northwest with where the resources are not as plentiful, especially in the remote communities. We had the opportunity to be in Sudbury maybe a year or so ago as part of our initial work with dementia capacity planning and a focus group with the Northeast LHIN and really have that conversation about what services are available in Sudbury versus and Timmins and North Bay versus what's available in the much further remote flying communities and how we address those needs with an equity lens right across the province.
And so Valerie in the Northeast reminds us that the care should be integrated with specialized geriatric care, memory clinics, primary care, and CCAC. And Dr. Liu reminds us that caregiver support should be included as well.
Absolutely agree, Valerie. Thank you. Nice to see you on the call, and certainly recognize that what we're trying to show on this slide. I really want to focus on the green hashed arrows about the referral patterns and how we integrate these pieces. As I said, this is a bit of it's more than back of napkin. Of course, we've given it thought, but we're not baked on this, and so we're still very much looking to take advice and feedback on how we would integrate the specialist geriatric services, the memory clinics, primary care, and others across this. I think that the RGPs and the RGPO can give us a unique insight onto how best to make this happen, and I want to make sure that we keep that conversation going.
Definitely opportunities to collaborate. And very quickly, behavior support outreach teams in the community and support for younger than 65 people that suffer from dementia.
Yeah, thank you, Stacey, for that question. It's a real challenge for us. One of the things that we've been tasked to address is the needs for people who are living with a dual diagnosis, who are living with ABI, for instance, or who are under the age of 65, sometimes well under that age, who tend to be referred to or only have the opportunity to live in long-term care, and that is so clearly not the best care setting for those individuals. We've been looking at that. We've been in conversations with our colleagues in some of the other social service ministries, community and social services, as well, to make sure that we try and address those challenges and come up with some solutions. We have both the benefit and the challenge of a boss, Sharon Lee Smith, who was an assistant deputy minister in Saskatchewan, before coming here, where they actually have housing options for people who are under the age of 65, who would otherwise be in long-term care, that is more specifically tailored to the needs of younger individuals. So we've got that, we have that line of sight, but also that pressure of if we can do it in Saskatchewan, we can do it in Ontario. And we've been having some interesting conversations with some groups like CGI, who operate some homes in the Champlain area and are looking to expand their presence in the Toronto area, in the GTA, who provide specific homes for special needs to address the needs of this younger population. Early days on that, a conversation that is still ongoing.
Michael, we have one more content slide. I'm wondering if we should get back to that, as people will have their next appointment to go to in about a minute.
Okay, thank you, Ken. So the next steps, I think we've talked about this. We can go through this quickly. We're developing an implementation now. We want a plan now. We hope to be in front of government over the summer. We do still anticipate drafting a public-facing document that will be released later in 2017 that ties all of these recommendations to government together and talks about how we plan to address them and what our evaluation process will look like as we move forward. And then really the conversation, and we've had such a great one today, and I want to keep this going, is how we can continue to work together with the RGPs and the RGPO, but also how we can continue to talk with the specialist community, how we can access some of the good work that's happening in places like Waterloo, Wellington, with the e-referral and the e-consult programs, and how those places, how that can come into play. I know an hour wasn't very much time, and I probably talked a little too much, but this has been terrific for us. And Ken, I will leave it with you and Barbara as to how we can keep the conversation going.
I'll just quickly wrap up there, but I just want to echo as well, the lively conversation really shows how important this topic is for everyone, and we've had such a great distribution in our audience. There were comments from acute care people, from the community service sector, from home care. We heard from some patients and caregivers about their challenges, and so I really think it's been a very rich conversation from a very diverse crowd across the province. I know that Dr. Liu would like to make some comments and thank your team, Michael, for all the time and effort you've spent to prepare this presentation. Dr. Liu, would you like to come on the line and say something?
Thanks, Ken. On behalf of the RGPs of Ontario, I just want to thank you, Michael, and your team for your incredible leadership on this strategy. You've all been very responsive to the feedback, and thank you for the opportunity for us to give feedback in the process to date, and we look forward to continuing to engage with you as this strategy is implemented. It was an incredible conversation today, and lots of excellent feedback and thoughtful contributions from the participants on the webinar today. So I want to thank everyone for joining in. And again, we look forward to continuing this conversation with you. Thanks very much.
Yes, and I'll close it out. I'd like to thank everyone, especially everyone on the RGP of Toronto team who assisted me with all this technical preparation for this event. You are all in the audience on my email mailing list, and what that means is very shortly you'll receive a quick evaluation survey. Please share feedback on this session and on what you'd like to see in the future. I will also send all of you, as well as all who registered, a copy of the recording so you can review the questions, the content and the questions of this webinar. And of course, we offer continuing webinars. Here are some of our selections we are arranging for you in the summer and early fall. There will be a presentation on the Senior-Friendly Care Framework, an intersectoral framework that our office here has been working on for the past slightly more than a year. A speaker from the UK on a mobility campaign in hospital called End TJ Paralysis. And our own colleague Tabitha Bowers from the Scarborough Hospital will talk about nurse practitioner role in evaluating driving. So thank you very much. We look forward to seeing you at those events. And again, a big thank you to Michael and his team for this really, really informative presentation.